Yeah. I'm gonna have to.
You can see that.
All right.
Mm-mm.
Boy, it has to be just in the right spot.
Welcome, everyone. Thank you for joining us. We'll just give it a few moments for everyone to get logged in. All right, let's get going. So welcome to our Baptist Behavioral Health Grand Rounds. We want to thank you for joining us this afternoon. I'm Dr. Francesca Varello-Sims, Director of Education and Training for Behavioral Health. And before I begin, I just want to make a few notes about today's presentation. If you have any questions for Dr. Miller, please feel free to either put them in the chat or the Q&A. I'll be moderating those throughout, and then we'll have a Q&A session at the end. At this time, please do sign in to the chat with your name if you're joining by phone, so we can make sure that we know everyone who's with us and we can give credit as appropriate. I'm going to pass it over to Dr. Terry Andrews now for the biography introduction.
Hey, everybody, and welcome for our May Grand Rounds. It is Mental Health Awareness Month, and so we are so glad you are here with us. I have the pleasure to introduce Dr. Holly A. Miller. She is a professor in the College of Criminal Justice at Sam Houston State University in Texas and is a licensed clinical forensic psychologist. She graduated with her PhD from Florida State University, go Noles, and developed the Miller's Forensic Assessment of Symptoms test, also referred to as the MFAST, with her dissertation project. Dr. Miller teaches, researches, and engages in forensic practice in the areas of assessment, risk, and treatment efficacy. She has published several journal articles, and I mean several, and book chapters on the assessment of malingering and the utility of MFAST to detect malingered mental illness. So with that, welcome, Dr. Miller. Thank you so much.
Thank you very much, Dr. Andrews. My name is Dr. Holly Miller, and I'm a professor at Sam Houston. I've also been a licensed clinical psychologist for the last 22 years. I did my bachelor's work at Bethel College in St. Paul, Minnesota, where I'm from, then my master's at Morehead State, and then, like Dr. Andrews said, my PhD at Florida State. After my PhD, I came to Texas to complete my internship at the Baylor College of Medicine in Houston, and I've been in the surrounding area since. So like Dr. Andrews said, the majority of my teaching, research, and practice has kind of revolved around psychometric assessment, starting with the MFAST, and I also do research and teaching in risk assessment for individuals who have offended. I have two published measures, the MFAST and the IRONS. The MFAST we will talk about today. The IRONS is the inventory of offender risk needs and strengths, and that's a risk tool designed to assess treatment targets to help individuals reduce the likelihood of recidivism. I am extremely honored to be here and talking with you today about an important topic, malingering mental illness, and using the MFAST to make more efficient and hopefully more effective decisions in your emergency departments. I will go over a few slides and then I will leave about 10-15 minutes at the end for questions, comments, or snide remarks. First, some interesting, perhaps, facts about the MFAST. The MFAST was my dissertation project that was birthed at the Chattahoochee State Hospital in Florida. I was a practicum student at Florida State. And while I was there, I noticed that we had a pretty large percentage of individuals who were attempting to malinger mental illness. I don't know if Florida still has the 3 strikes law, but we had a lot of folks that were on their 3rd strike for a drug offense, and they were attempting to malinger mental illness. As a practicum student, I was kind of in charge of doing the testing and all of those things required for the team to make an appropriate diagnosis. And I found myself spending a lot of time, since we did suspect malingering quite often, doing, I guess, administering the only validated tool at that time, which was the SIRS, the Structured Interview of Reported Symptoms. And that one takes anywhere between 1 to 2 hours to administer, and longer sometimes if a person has a bona fide mental illness. So that's when I kind of determined we really need some sort of malingering screen that can help us at least screen or detect malingering in a much more efficient and both cost effective and time effective manner. So I started working on that particular project. I spent a lot of time working on that, collecting data. So my dissertation was a result initially and developed on Florida folks at the Florida State Hospital. Dr. Terry Andrews, your VP for behavioral health, was one of my undergraduate research assistants. And I must say she was my favorite one. The MFAS is purple because I am from Minnesota originally, and I have a passion for my Minnesota Vikings. Later on, when I developed the irons, I created that to be garnet to represent my love for FSU. The most notable recent MFAS use was on a pretty large scale over the last week, and that was at the Depp Heard trial, where a forensic psychologist from New York was hired by Amber Heard's team to evaluate her and try to obtain a diagnosis. And she administered about 27 different tools, including the MFAST, to demonstrate that she was not exaggerating or malingering a mental illness and that she really did have post-traumatic stress disorder. So that was kind of an interesting scenario. She scored 0 on the MFAST, which I'm a little suspect. I'm guessing that she was coached. And then the last interesting, perhaps, is that when I do revise the MFAST, it will be the MFASTer. So today, over the next about 45 minutes or so, we're going to talk about the problem of malingering, particularly what research indicates about malingering in the emergency department setting, the kind of overall assessment and theory of malingering. So how do people malinger? Under what circumstances do they malinger? Do some comparisons of the DSM-5 criteria compared to clinical opinion, and those compared to also a formal assessment of malingering, and then spend the majority of the time talking specifically about the Miller Forensic Assessment of Symptoms test. My plan is to leave some time at the end for you guys to be able to ask questions, so please feel free to put that in the chat or write it down. And then I will try to answer them as best as I can. So the problem of malingering. The American Psychiatric Association defines malingering as the purposeful exaggeration or fabrication of psychological or physical symptoms motivated by external incentives. The prevalence of malingering is a lot higher than most people think. Even in general evaluations, research has indicated that about 8% of individuals are grossly exaggerating or fabricating symptoms. In forensic evaluations, that significantly increases, and depending on the population, research has indicated that 20 to 54% of forensic evaluations, people are engaging in feigning or malingered mental illness. What the research has shown us in the recent past is that around 20%, some research says greater than 20% of individuals coming into emergency departments with psychiatric symptoms are engaging in malingered mental illness. And that's the area that we will focus on today. So accurate assessment of symptoms is really important. There are huge consequences, as you guys know, to say one or the other, to say someone is malingering or to say someone is not malingering, and have them take a bed of someone who does have a bona fide mental illness. Malingering mental illness costs American insurers an estimated $150 billion a year, which is incredible. Provides appropriate medical and legal outcomes, reduces unnecessary expensive hospitalizations, and reduces the abuse of valuable and very limited mental health services that we have. So one of the studies that I wanted to talk a little bit about was Rumchick and Apple, and a couple of years ago they published this article, and they're out of Mount Sinai Medical Center in New York City. And what they did is they kind of wanted to get a base rate and look at commonly malingered symptoms and diagnoses that they were having some issues with. And so they did a very complete evaluation and a bunch of testing, et cetera, with every patient that came into their emergency room with psychiatric symptoms over 1 month. And that included 429 patients. The physicians reported that malingering was suspected initially in about 33 or a third of the cases that came in. And after questionnaires, after interviews were done with the physicians, they found that they really strongly suspected or knew about 20% of individuals were malingering mental illness. They found in their sample of that 400 and some that the majority of folks coming in with psychiatric symptoms to their emergency department were trying to malinger suicidal ideation, and then depression, and then psychosis. These were the top 3 set of symptoms or diagnoses that people were engaging in malingering the most. What they found too is that they did questionnaires and asked also that each participant or patient that came in kind of what they were looking for, and found that hospital admission, a stay in the psychiatric center, or seeking housing or social work services were the main gains that they were looking for in their malingering. Zubair et al. A couple of years ago, 2014, published an article entitled "Screening for Malingering in the Emergency Department." And what they did is kind of an overview of research that has been done and reported on some of the issues that are often needing, I guess, to be confronted in emergency departments when folks are coming in with psychiatric symptoms. In their research, they reported that a high percentage of individuals coming in were suspected of malingering. Most were not confronted about their symptoms or given the V code of malingering. The authors state that a thorough understanding of potential signs of malingering is required in emergency departments, that clinical skills alone and using the DSM are not going to be enough to effectively identify or de-identify individuals who are malingering. In their prior research, they found that 3 out of 10 patients diagnosed with malingering in an ER were later found to be diagnosed with bona fide schizophrenia. So not only do sometimes we have in our clinical opinions false positives, we also have false negatives. So clinical opinion, and I'm going to talk a little bit about the research on clinical opinion and what it says of how accurate we are as professionals in mental health at correctly identifying malingering. So the authors report that validating a screening tool or using a screening tool for malingering is warranted and would help considerably. In fact, they gave this quote: "A screening tool for psychiatric malingering could increase confidence in making decisions on patient dispositions, decrease the liability for the clinicians, decrease the likelihood of error based exclusively on clinical judgment, and improve efficiency and utilization of hospital resources by avoiding unnecessary hospitalizations due to feigned psychiatric mental illness." In fact, then they go on to suggest actually that emergency departments should use the MFAST, which is cool. Zwick et al. Did a case study last year. It was published entitled "Malingering in the Emergency Setting." And they kind of did this case study of it was a 50-year-old male that came in with psychiatric symptoms that were pretty preposterous, etc. So they had suspected malingering. So they talk in this study about that particular case and the difficulty they had in determining whether he was malingering. They report that malingering detection in emerging departments is becoming critical for appropriation of limited resources. And they suggest that emergency departments use the SIRS or the MFAST with focus or emphasis on the MFAST because it is a more efficient way to assess malingering, particularly with folks who have a bona fide disorder. Like I said, when I was doing a million SIRS, if someone did have a bona fide psychiatric disorder, it took a very, very long time to do that booklet and ask all of that, all those structured interview questions. So the DSM-TR had malingering as a index diagnosis and was defined as the intentional production of false or grossly exaggerated physical or psychological symptoms motivated by external incentives. The DSM-5 removed malingering from the index diagnoses. However, it still remains as a V code when malingering is suspected, and includes these 4 things as situations where malingering should be highly suspected. Assessments that occur during litigation or other medical legal evaluations, when the person's reported symptoms are not consistent with testing or collateral information or history, when the individual is uncooperative with the evaluation, when the individual has a co-occurring APD or antisocial personality disorder. And we will talk about some of the issues of these particular criteria for malingering and how difficult it is particularly with producing false positives. So using the DSM criteria as well as clinical opinion on the assessment of malingering has created a lot of diagnostic issues. A lot of false positives, a lot of false negatives, and I'll present some charts here in a minute on some of the research. Malingering or feigning also is not always yes or no. As most of our diagnoses, even though we have to have a threshold and say yes or no, someone has diagnosable depression or someone has diagnosable schizophrenia, we know that symptoms are on a continuum, and it works the same way with malingering or feigning. Research indicates that, like other diagnoses, malingering has been found to be dimensional, not categorical. Walters et al. Did some studies a while ago and found feigned psychiatric and neurocognitive symptoms, dimensional structures on several measures of response style. So oftentimes, and these tend to be the trickiest cases, if someone is exaggerating a little bit, or if someone is a bona fide patient, but do not have insight into that. And so they feel like they have to fake mental health symptoms to be able to get help, makes this even trickier to figure out. So some of the explanatory models of why people would engage in malingering, we kind of first start out with this pathogenic model, that someone had to be kind of have a mental disorder already, but not really having insight into their mental illness, and so feel like they have to engage in symptom exaggeration or even symptom fabrication. So these are typically considered bona fide patients who don't have a lot of insight into their functioning, and feel like they need to exaggerate to be admitted to the hospital, or fabricate some symptoms so they can get the medication that they found the most helpful, etc. A great example of this was a patient that I worked with at the Florida State Hospital. He came in as incompetent to stand trial for 2 counts of murder. He had shot and killed 2 men who were wearing suits in a 7-Eleven that he was in. And while in jail, it was determined, and he was evaluated to have significant mental health issues, and was found incompetent to stand trial, and then sent to the Florida State Hospital to be restored so he could go back to the court. When he came in to the Florida State Hospital, I'll never forget it, because his symptoms were pretty out there, pretty preposterous, really hard to believe. And then some symptoms were right on. He reported that these 2 men in the 7-Eleven were CIA agents. That's why they were in suits. And they were there to take him to their van, and then insert a chip into his brain so they could record all of the secret governmental information that he had for the United States. And then they would, once they kind of sucked out all that information from his brain, they were going to remove the chip and then kill him, is what he was reporting. He reported several other outlandish hallucinations and delusions. And as a team, we really thought that he might be malingering. So I included several malingering assessments along with the standard protocol. He did elevate several of those, but it still seemed that something was missing. So even when staff weren't looking or he wasn't under assessment, he was still engaging in very bizarre psychotic symptoms. And eventually, after more testing and time, he was diagnosed to have paranoid schizophrenia, and then he was treated accordingly. But he believed that he needed to malinger to present symptoms in order to get help, and hopefully not to be found responsible for killing those 2 men. He had very, very little insight, if any, into his actual mental health, but this was really a great example of this pathogenic model of malingering, and one of the situations in which it does make it more difficult when someone does have a significant mental illness, but do not have a lot of insight into it and feel like they have to malinger anyway. So it's kind of hard to tease out what is real and what is malingered. The next explanatory model for malingering became a criminological model. And the criminological model believes that individuals who malinger are antisocial, and malingering is just kind of an artifact of being antisocial and an antisocial act. We've come from that, and now for the most part, we think of malingering as more adaptational, trying to make the best that they can out of their particular situation. So if they feel like they're going to go to prison for the rest of their lives, it makes sense to see if they can get out of it, to see if they can be deemed mentally ill versus going to prison for the rest of their life. And I'm guessing that's where a lot of people are coming into the emergency departments. They're trying to figure things out. They're trying to seek food, shelter, a respite, etc., and potentially help. One of the other diagnostic kind of tricky things in the assessment of malingering is differentiating fictitious disorder versus malingering. And the biggest differentiation here is motivation. So as the DSM reports, to be malingering, the feigning, the faking, the fabricating of symptoms for some sort of external reward. With factitious disorders, these individuals, there is no known or external reward that can be figured out. But with fictitious disorder, the reward is internal. So being in that sick role so fabricating or exaggerating or making themselves sick, in fact, to kind of maintain that sick role. So that is the best way to differentiate between those diagnoses. So over the years, we have figured out, I guess, what are common strategies that people use for malingering. And then these strategies we use to detect malingering. Rare symptoms is probably the most that provides us the largest effect in determining whether someone is malingering. And rare symptoms is infrequently reported symptoms in bona fide psychiatric patients. Like there are several symptoms that you'll see once in a while in a bona fide psychiatric patient, but less than 5 or 10% of that population, we call these very rare symptoms. And malingers tend to over-report these infrequent symptoms. And this strategy has been one of the best strategies that we've noticed to be able to detect whether someone is malingering. Some examples of rare symptom endorsement. We know that less than 7% of bona fide patients with psychotic symptoms report hallucinations that are vague or inaudible. A malingerer will often report such rare psychotic symptoms if you ask them. Additionally, rarely does a bona fide patient with psychotic symptoms report that they always obey command hallucinations if they have command hallucinations. But for someone who is fabricating a mental illness, that sounds very mentally ill, and they often endorse that. It is also rare that patients with psychotic symptoms report tactile or olfactory hallucinations. However, malingerers do. So the more rare symptoms of varied diagnoses that someone endorses, the higher likelihood that they're going to be malingering. The next one is an indiscriminate symptom endorsement. So endorsing a large proportion of symptoms, not only in one diagnosis, but oftentimes out of several diagnoses. The next one, extreme or blatant symptoms. This strategy capitalizes on the finding that even severely impaired patients experience only a discrete number of symptoms as unbearable or extreme. Malingerers tend to endorse a wide array of psychological symptoms that are blatant, that are extreme. Example, hearing voices all of the time. So if someone reports that they are constantly hearing voices and the voices never go away, we know that that's not the case in bona fide patients that have a psychotic disorder, and that is indicative of someone exaggerating or fabricating. If someone endorses that they see people that are extraordinarily huge or tiny individuals, if they see individuals in black and white versus color, we know that these are very extreme symptoms. When individuals do see people, hallucinate people, in other words, that aren't there, they report seeing them in normal size and in color, just like we see anyone else. So when someone is endorsing something that's so extreme and blatant, but it sounds, very psychotic, it's indicative of malingering. When someone reports that they feel suicidal or depressed at all times during a week or month or however long you ask, when we know individuals with bona fide depression and suicidal ideation, those symptoms wax and wane. They're not always maxed out and feel like they want to kill themselves, and they're not always in a very deep hole of depression. Those symptoms kind of wax and wane for individuals. So if someone is reporting that they're feeling suicidal, all of the last week, every single minute, or they have significant depressive symptoms that haven't changed in a month, that is indicative of someone who is endorsing kind of an extreme, blatant symptom of a particular disorder. The next strategy, improbable symptoms. And this is when individuals are attempting to malinger, they will report symptoms that have a fantastic or preposterous quality. For example, when I hear voices, I hear them every day at 4 p.m. I feel suicidal every day at 10 a.m. So just things that are improbable, and to have individuals report a lot of these different improbable symptoms is indicative of feigning or fabricating a mental disorder. The next strategy is reported versus observed. So this is when there is marked discrepancy between what the patient is reporting their symptoms to be and what we as clinicians actually observe in our interview or on the particular ward or in the intake area, etc. So they're reporting certain things and we're just not seeing it. For example, I always have to take deep breaths while sitting in a chair. So most likely you're in an interview with them. And if that's something that you ask them and they endorse, but you're not seeing them constantly engaging in deep breaths, that is a sign. If they report they're always having to look under or behind chairs wherever they're sitting, but you have not seen that in their behavior at all, or when they report that when they move into a new room, they have to check under everything, or they have to get on their hands and knees to inspect and make sure no one is hiding that's going to get them. All of those things are signs that they could be malingering, and the more that they endorse these symptoms that are not actually clinically observed, the higher the likelihood. The next strategy for malingering as well as detection are rare combinations. So a lot of individuals who are feigning or completely fabricating a mental illness don't have a really great idea of what symptom goes with what disorder. They're very likely to engage in reporting symptoms of several different combinations. And we know that certain symptom combinations rarely go together or rarely diagnosed together. For instance, having someone report grandiosity, feeling like they can rule the world, and then also report at the same time that they have an increased need for sleep. So anytime that individuals are reporting these rare combinations of symptoms, that's also a sign. And then lastly, unusual symptom course. Oftentimes individuals who are feigning or fabricating mental illness, they're not really aware or educated on common symptom course or prognosis or how things progress through time, and will endorse things that don't make sense, like someone turning on and off their symptoms. So they're not going to know exactly how they're going to feel at several different times during the day. So decades of research has demonstrated that validated tools are significantly more effective for diagnosing malingered mental illness. And even in situations where people have years of experience, of diagnosing and understanding symptoms of mental illness. Studies have been very, very consistent in indicating that it is much more effective to use a validated tool than any kind of use of the DSM criteria or clinical opinion. We are often inaccurate. And this is one of the things that I learned in graduate school, which was very disappointing to me because I thought I was going to be an expert and I could just tell, et cetera. And that's just not the case at all. We're really bad, actually. And I'll talk a little bit about some of those statistics. So why we don't use clinical opinion or clinical judgment, just looking at the DSM criteria, you know that you're going to miss a lot of people here, especially in the setting of an emergency department. You're not doing a forensic evaluation. Most of those individuals are going to be cooperative because they want to be assessed, they want to be admitted. And maybe some of them will have antisocial personality disorder, but a lot will not. So the accuracy of using this criteria is in the 20% range. So research has indicated that individuals that just use those four, I guess, kind of criteria for the B code of malingering are 20% accurate. You would be better off flipping a coin than using just the DSM criteria. You'll be more accurate that way. Utilizing these criteria results in a lot of high false positive rates, especially in forensic evaluations, and in a lot of in emergency departments where there isn't forensic evaluations going on. A lot of times it's opposite, and you have false negatives. So not calling someone malingering when they actually are. So research over the last several decades has reported on the accuracy of clinical judgment, and not just with malingering, with all sorts of issues, whether we're trying to predict risk of whether someone is going to offend again from our expertise, or we're trying to determine whether someone is malingering mental illness. Studies strongly support that objective assessment, the use of validated tools, are significantly more accurate for diagnosing malingering. So in one of the first studies that I did, I wanted to kind of compare how the MFAST was functioning with clinical opinion. And so this was published in 2005. It was an ongoing project. Study one included my initial developmental sample from Florida State Hospital. And I wanted to look at whether clinical opinion differed in accuracy from using MFAST items to see how the MFAST, if it was generalizable across race and ethnicity and literacy. We're going to focus on the clinical opinion for our time together here. So in study one, the initial MFAST items, I initially wrote 79 items, and I wrote them according to those, I guess, those strategies that we just talked about. So I took each strategy and wrote several items underneath each one of those strategies. And the first thing to do is kind of test them all out and see which items are functioning better for final inclusion on the measure. So in study one, I used the initial items. They were 79 items. And we assessed 280 forensic patients, 5 psychiatrists, and 8 psychologists. And what we would do is meet as a treatment team like we always did. When someone came in for an intake, oftentimes we would see them as a team and sit down and talk about why they were there, the symptoms they were experiencing, etc., and spend a good deal of time talking with them. And at that point, after that, I would get the psychiatrist's opinions, the psychologist's opinions on whether they thought someone was malingering or exaggerating mental illness. And then after that point, I went and did my usual kind of testing, overall testing, as well as the MFAST items, the SIRS, the M-test, and the MMPI-2, and looked at some of the response styles on the Minnesota Multiphasic Personality Inventory. Once the final items of the MFAST were selected, I did another study, and we used their 50 forensic patients. And again, the same 5 psychiatrists and 8 psychologists that were working at the state hospital. And the scenario or the procedure looked similar. So in the first study, you can see by the receiver operating characteristics and areas under the curve on the right side listed in these figures. Psychiatrist opinion still was significantly above chance at 0.72. That green line, that diagonal green line up the middle, that indicates chance. So the closer that the other line is to that, it's like flipping a coin. So the psychiatrists were significantly above chance with an area under the curve of 0.72. But they had 19 false positives and 17 false negatives. So 19 people they called malingering when they were not malingering, and 17 people they said were not malingering, and gave them a mental disorder diagnosis, but they were indeed malingering. Psychologists were about the same at an area under the curve of 0.80, and they had 15 false positives and 11 false negatives. So they called 15 people malingering when they were not, and 11 people they called as a bona fide patient, and they were actually malingering. The MFAST initial items had a significantly higher area under the curve compared to psychologists and the psychiatrists at 0.89. I couldn't, figure out false positives and false negatives because there were no cut score at this time of the MFAST. I just included all of the particular items. In the second study, so this was with 50 psychiatric inpatients, same scenario. Psychiatrists had an area under the curve of 0.65, significantly better than chance, but still 14 people were misclassified. 7 people were called malingering and they were not. 7 were missed. Psychologists, area under the curve, very similar, 0.73, and they had almost the same amount of misclassifications, 9 false positives and 4 false negatives. The MFAST in the final version with a cut score of 6 produced a significantly higher area under the curve at 0.95 and had 6 false positives and missed 1 individual. Since the MFAST was developed as a screening instrument to screen people in or out initially and then allow for further investigation, particularly if they scored a 6 or above on the MFAST, additional malingering assessment is done. So the bar or the cut score was set pretty low. If you're going to use it as a screening tool, 6 seems to be the best way to do that. So you're okay if it's a screening tool to have a higher number of false positives because you're going to do additional assessment. You're going to continue assessing them and making sure that indeed they are malingering before you take away any kind of treatment or send them back to court or deny services in the emergency department, etc. So as a screening tool, it's okay to see some false positives like that. And in this particular sample, we had 1 false negative. So the MFAST missed 1 individual who was called not malingering, but they actually were. So development of the MFAST. The MFAST, like I said, the items were developed to operationalize those response styles and those strategies that have been validated for identifying individuals who are malingering. Reported versus observed symptoms. On the MFAST, I have 3 items that assess this. For instance, I always have to take deep breaths when sitting in a chair, when sitting down. Extreme symptomatology has 7 items. And those are individuals who are endorsing that kind of extreme, blatant symptoms. For example, I feel depressed all of the time. The severity never changes. I hear a radio playing when there's not a radio on near me. Having a hallucination of music is very, very rare in people who have psychotic disorder. So those are some of the examples of those 7 items on the MFAST. Rare combinations also has 7 items. And these are, again, combinations of different disorders or combinations that don't typically go together. I feel so depressed, I can't remember my name, is an example of one of these on the MFAST. So looking at depressive symptomatology and so depressed that you have cognitive impairments. Although we do know individuals can have some cognitive impairments with significant depression, they can usually remember their name. The next scale is unusual hallucinations, and there are 5 items on the MFAST. Hearing voices from only one ear, seeing people who are very tiny and green as opposed to normal size and in color, hearing music from nowhere, etc. Are some of those. Unusual symptom course is 1 item, and that is about endorsing someone else, kind of controlling their symptoms, turning them on and off, etc. Negative image. A lot of individuals who are malingering or fabricating mental illness believe that folks that have a mental illness must not feel very good about themselves, must have a low self-esteem. And so they feel like they also have to let you know that they don't feel very good about themselves or they have a low self-esteem. And then the last item, and one of the most robust or large, I guess, effects for the MFAST is the suggestibility item. Individuals who don't know a lot about mental illness but are trying to malinger or fake mental illness are very suggestible. So on the MFAST, I suggest at the very beginning that there are certain symptoms that happen when someone is severely mentally ill and they have to sit and do an interview or concentrate for a long period of time, like this interview that we're about to do. And then I ask them at the end, did they experience that symptom? In all of my developmental samples of the MFAST and research since then, not one bona fide patient has ever endorsed that. And a large chunk of individuals who are malingering have endorsed that. So just that item alone is very robust in predicting whether someone is malingering or not. So the MFAST is a structured interview, 25 items representing those kind of proven detection strategies. It takes about 5-10 minutes to administer. The scoring is approximately 10 minutes. It does not require the examinee to be able to read. The examiner, yes, of course. It has been translated into several languages, Spanish, Turkish, Korean, Armenian, and a few others. And it was developed using both known group and simulation studies. So in known group design, like the study that I talked about at Florida State Hospital, they're known groups because we know that they're actually some of those individuals are bona fide patients and some of them are bona fide malingerers. But unless someone admits to it, unless someone says, yes, you're right, you caught me, I'm malingering, I'm trying to get away with murder or whatever it is, you don't know absolutely for sure. So simulation studies are very important too, where you have a group of community people that you ask to answer honestly, and then another group that you tell them to malinger. And we've done the same thing with bona fide patients. Bona fide patients, I want you to answer this honestly. And then another group of bona fide patients, I want you to pretend like you're exaggerating or you're malingering a mental illness. So both of those have been used in the development and validation of the MFAST. The MFAST materials include an 8-page interview booklet. I'm going to see if I can show some of it here. This is what the booklet looks like. Oh boy, with the blur, you can't really see it much, but I'll explain it. So on the front is identifying information, and then there's a whole section of MFAST scale scores and then the total score. So all of the scoring, etc., all of the interview questions are in here. You can score as you go, and then you put the scale scores of each one here and then add up for the total score. And then you have an idea with probabilities, etc., from both the professional manual as well as right in here inside the interview booklet of probabilities of different cut scores. The MFAST has been validated on folks 18 years and older with different ethnicities and racial groups, validated across sex, and validated in several different populations: prison populations, folks on probation, forensic hospital, civil hospital, outpatient disability assessment, inpatient psychiatric center associated with local emergency departments, and validated in several languages. So interpretation of the MFAST is distinct for most forms of psychopathology. However, we know that the presence of malingering does not necessarily rule out a psychiatric disorder. We know that there's significant consequences for a malingering diagnosis or missing someone who is malingering. So choosing a cut score is very important. As I said, if the MFAST is used as a screening tool, 6 is suggested as a cut score. So out of 25, if someone scores 6 or above, they are suspected of malingering. Now that is low, right? And when it was set up to be a screen, it allows for more false positives. So the higher the cut score, the higher the probability of malingering. And there's been different research with different populations that have indicated different cut scores. So emergency departments typically are not going to engage in the SIRS even after the MFAST indicates. It's just isn't enough resources and time to do something like that. So you probably want to use a higher cut score in these particular situations. For example, Veazey et al. In 2005, that's one of the studies in a psychiatric center associated with an urban public hospital. They found that a cut score of 8 produced the most accurate classification. Glassmeyer et al. Published a study in 2016 that reported on several different MFAST cut scores and how they corroborated with SIRS results. So an MFAST cut score of 6 was met with 78% rate of appropriate diagnosis of malingering. 10 was associated with 88%, 12, 91%, 16 with 100%. There are 3 levels of interpretation with the MFAST: the total score, the scales, and the individual items. The total score is the one that is used the most, and it provides just an interpretive statement of whether that someone has met the cut score and seems to be malingering. Scales provide a more nuanced interpretation. Scales do have their own cut score. If someone is malingering a diagnostic specific disorder, some of the scales in of themselves tend to be better predictors. We know from previous research that in emergency departments, people are much more likely to malinger suicidal ideation, depression, and psychosis. The MFAST does provide assessment for malingered diagnostic specific malingering. So if someone is coming in and saying, I'm going to malinger depression, myself and some of my research team found that the MFAST was effective to detect malingering to face specific diagnoses of schizophrenia, major depressive disorder, bipolar disorder, or post-traumatic stress disorder. And other studies have found similar results for diagnostic specific malingering. And in the last few slides, have a list of validity studies, as well as studies for diagnostic specific malingering assessment, some of the competency to stand trial, forensic inpatient, civil settings, etc. I'm not going to talk about all of those because I do want to leave a little bit of time for questions, comments, or snide remarks. So thank you.
Thank you, Dr. Miller. Great presentation. So we have several questions for you. I'm just going to quickly answer a couple that you went over, but just to reiterate, so the assessment takes 5 to 10 minutes to administer, and then about another 10 minutes of scoring. And yes, Dr. King, we do have the MFAST available at Baptist Health to be utilized for our patients. And then really briefly, Dr. Miller, you mentioned it was validated in medical settings, and that includes emergency departments, correct?
Yes.
Okay, great.
Mhm.
There you go, Dr. Hirsch. And a couple people were interested if you have or have considered an MFAST for pediatric patients, because you can imagine we get that population in the emergency department as well.
I have never assessed individuals younger than 18, mainly because the majority of my clinical work and research focuses on adults. I know that there has been some interest. I've talked to several people who seem to be studying it, but I still haven't seen any published works on it. It's validated for 18 and above. I'm guessing the higher years, especially of adolescence, it would be fine, but there is no, I wouldn't put a lot of money on it because there is no validation of teenagers or younger.
Have you ever, considered what that population, the sample would be for a pediatric one, if you could design a study?
No, I've never thought about it, but I think it could be done in all sorts of different situations, whether it is someone coming in and seeking shelter or medications, or someone needing or trying to get out of something, but particularly if they're older adolescents. So in a juvenile detention facility, et cetera, I think there'd be several kind of populations that could be used for validation of teenagers.
Absolutely. Do you find that borderline personality disorder is a frequent, co-occurring disorder with
malingering?
Mm-hmm.
Well, absolutely, depending on the setting, right? So in your setting, I think you'd find that a lot because the majority of folks are trying to get medication or trying to get off the streets or trying to get some safety, et cetera, where suicidal ideation or depression is more likely to be malingered than other things. So absolutely.
Mm-hmm. And in your studies, one of our providers asked if the patients were blinded or did they know that they were being screened for malingering in particular?
They were blind.
Okay.
Now, in some of the simulation studies that we've done, either with bona fide patients or community people, or we use some students when I was collecting initial data, then they knew, right? Because we would tell them, we want you to answer honestly, and then we want this group of bona fide patients to malinger, malinger a disorder, fake a disorder.
Mm-hmm. Gotcha. And one of our staff members, so they noted they don't see a psychologist dedicated to our ER setting. And so they're wondering if there's training that a nurse or other healthcare staff can take. We're actually working on that actively. We're hoping to bring to you all training on correct administration and interpretation of the MFAST in August, hopefully, is our goal.
Yes. I'm planning on it.
Yeah, I can't wait. And where would religious visual hallucinations like angels or demons fall within the different scales in the MFAST? Would they be authentic, rare, or considered malingering?
I don't, I tried not to include hallucinations of such or hallucinations that are more common among people that have traumatic brain injuries because those individuals tend to have some different types of hallucinations. And it's just kind of too hard to detect there. So I don't include hallucinations of a religious nature, or more common, still bizarre hallucinations reported from individuals who have a brain injury.
Mhm. And Dr. Hirsch was wondering if substance use is considered in the MFAST. Do you perform it on intoxicated patients? And in a similar vein, does, capacity or mental status, does that impact the reliability of results?
Oh, absolutely. It would. I would not administer the MFAST to someone who is actively under the influence of a substance. I would wait some.
Mhm.
I mean, I guess some of it depends on the impairment, right?
Right.
How someone, if someone is greatly impaired, then it's not going to be a valid representation. If they seem to be answering other questions, okay, and under the influence of something, perhaps it might work out. But that's one of those instances that you say, well, I think they're malingering because they scored such and such, but it might be something that we administer again when they're not under the influence.
Sure. Yeah, because you know that you can give it in a battery in a forensic setting, like for somebody who's being found competent to stand trial. So there might be some level, you know what I mean, of impairment, but yeah,
Yes.
okay. So using clinical judgment there.
Mhm.
What recommendations do you have related to providing feedback to a patient and addressing, exaggerated performance?
That one is tricky for emergency departments, because typically you're not giving a full battery of tests, etc. So that one is pretty tricky in your environment. If you see that someone seems to be endorsing a lot of symptoms on the MFAST, that maybe have a high score on the MFAST, I might question some of those. I might confront them, and by confronting, I mean, you're still, gentle, but inquisitive, right? Inquisitive about their symptomatology. I might even say, it seems like, you're exaggerating a little bit in this particular area. Could that be? Because it is the trickiest part of malingering is differentiating someone who is malingering and who also has a bona fide psychiatric disorder.
Yeah, absolutely. It's a delicate dance, you know what I mean? Because you don't want to completely invalidate them when there is that element of secondary gain. And sometimes it's so tied to their life, like they need housing or they need medication, food. And so, yeah, it's very tough, especially in the emergent setting.
Right. And you have to make a fairly quick decision.
Right. Yeah. Doctor, it went away. It takes 5 to 10 minutes to administer. Somebody asked, just for clarification again. Dr. Hirsch would like to know if you have examples of ED physicians changing their Baker Act rates based on using the MFAST in the setting.
I don't have those numbers, but I have read a couple of journal articles in psychiatric journals, where people have examined kind of before or after of using a more formal assessment of malingering, and that did change rates. I don't know it off the top of my head. I don't remember who even wrote the article or what journal it was in, but I have read that, yes.
Any thoughts or background on why the DSM removed malingering as an index diagnosis?
I'm thinking because it's not really a mental disorder. And so they moved it to an area of concern versus what would be considered a disorder. Does that make sense? Yes,
absolutely. So I have pulled up the QR codes that can direct you guys to the evaluations. That is all the questions we have. Thank you so much, Dr. Miller, for your time today. We really appreciate it, and we look forward to seeing you in Florida, hopefully, in August.
I look forward to it as well.
Yeah, everyone, please reach out if you have any, follow-up questions. I can get them to Dr. Miller. And also please join our final grand rounds of the series, which is going to be June 24th. And Dr. Lodi will be talking about adult ADHD. Okay, I hope everyone has a great afternoon.
Thank you.
Thank you.
Okay, see you
Yeah.
guys. Bye-bye.